Today we're going to be discussing Corneal GP lens basics. So the outline today will cover GP indications, fitting procedure, evaluation of the fit, how to order, dispense, and follow up on a GP, and some basic troubleshooting. So a big question that I get is, with the advent of so many new soft lenses coming out that have a lot of new materials and designs, is there still a place for GP? I remember reading a review that discussed the obituary of rigid GPs, saying that, you know what, our soft lenses have come a long way. Maybe we don't really need them anymore. But as a specialty contact lens practitioner, I definitely don't agree with that. So when may we use GPs? I think one of the largest populations that we'll use them for are the irregular cornea population. People who have keratoconus, surgical scarring, or irregular corneas after surgery. The other patients who may have a normal cornea but still may benefit from GPs are those with high astigmatism, and this is best when their corneal toricity is similar to their refractive astigmatism. You may also have patients with high hyperopia, high myopia, presbyopes who have vision demands where they really want crisp vision without having to wear any glasses. Dry eye symptoms may be worse with soft contact lenses than GPs. And you may have patients who don't have a very high refractive error or unusual refractive error, but they have high visual demands and feel that they're not being met by the options available by soft contact lenses. And of course, we still have patients in orthokeratology who may be using it for myopia control. For the purposes of today's lecture, we'll be focusing on regular corneas. So what are some of the pros and cons of using GPs? I always talk to my students and tell them that proper patient selection is really critical. If you don't pick your proper patient, you'll be less likely to have a successful fit. So some of the pros, as we know, GPs afford excellent optical quality, while soft contact lenses, although they have come a long way, can still have some limitations on their parameters. For multifocals, all of our soft multifocals are simultaneous designs. They currently do not translate. Versus GP multifocals, we do have the option to fit a translating design, which can allow really sharp, uninterrupted vision at near. GPs have also been shown to be better for dry eye symptoms and overall ocular health. And so things like GPC and ocular infection have lower incidence in GPs. So what about the cons? The cons, I think, are fairly obvious right when you put a GP on. There is a period of corneal sensitivity and adaptation that a patient has to overcome before they can be comfortable wearing them. There's also an aspect of apprehension from the patient where they hear rigid or hard lens and they think, oh my gosh, this is going to be a really uncomfortable lens. And so that may give them some anxiety about going forward with the fit. In addition to that, I find that practitioners who are not confident and comfortable with presenting these options to patients can also inherently cause the patient to become a little bit more apprehensive too. If their work or hobby environment is limiting, so let's say they work in a dusty environment where debris can get under a GP, if they have hobbies like high impact sports where it may cause the lens to eject, this also might not be the best option for them. And we have to talk to our patients that fitting and follow-up time is going to take longer than an average soft contact lens. So I have down here at the bottom is cost a pro or a con. People seem to think that because a GP is a custom lens that it will be much more expensive than soft lenses. I will say that even though the actual upfront cost that a patient has to pay, so a little bit higher maybe fitting fee because of more chair time, and you have to pay for the custom lenses upfront to order them, that if you look at the whole fee for a whole year, soft contact lenses, particularly some of our premium dailies that are out right now, actually cost quite a lot more per year than a GP. So I don't really think of cost as a con per se, but I do want to let the patient know they may have to pay a little bit more at the beginning. So before putting diagnostic lenses on, what is the fitting procedure? Perform a good case history. Make sure that your patient is a good candidate and has realistic expectations about the adaptation process for GPs. Then you want to perform a good refraction. You need some sort of keratometry value, so whether that is manual or automated keratometry, or if you have a topographer available, that can also be utilized. And then I like to perform a slit lamp evaluation to make sure that the ocular surface is healthy, and I want to look at palpebral aperture size and lid position because this will be helping me in my initial lens selection. So refraction. Think about patients with high ametropia and or high astigmatism because they tend to be good candidates. They may be unsatisfied with the vision in their soft lenses or their glasses. Keratometry is going to help us choose an appropriate starting base curve and also determine if a toric or bitoric GP might be needed as opposed to a spherical base curve GP. If you look over at the photos on the right, you can see that the top image has a high amount of regular with the rule astigmatism. And depending on the magnitude, a spherical GP may not fit very stably on this eye. On the bottom, you can see that we actually have a cornea that is irregular, where you have steepening more concentrated at the inferior part of the cornea. So topography can also help us find out if a patient has an irregular cornea from a condition like keratoconus. And we might be screening for those patients, and it may affect the way that we design our lenses. So for the slit lamp evaluation, of course, you want to make sure the cornea looks healthy. You don't want to put a GP on an eye that may have an abrasion or something else that might preclude us from starting the fit. But I also look at things like anatomical features. I want to know how big the cornea diameter is. I want to know the palpebral aperture size, and I want to look at the eyelid position relative to the cornea, as again, this will help me with my initial lens selection. So what's the best method for fitting a first lens? A lot of practitioners have moved to an empirical model of fitting GPs where they will provide their lab with the refraction and keratometry values, and the lab will then design them a first lens. There are some benefits to this. One of the benefits is that you don't have to actually put lenses on in office, and the first lens that the patient may be able to take home will be in their own power and customized to them. I would say the downsides are that I think there's some benefit into having the patient experience what the lens feels like in office, but additionally, it's easier to see how the anatomy, such as the upper lid, will interact with a lens if you actually put one on. So I like to tell my patients that may be opting for an empirical fitting that this is going to act like a first trial lens because we will likely need to make some changes afterwards to get the best fit that we can. Diagnostic is what we've done a lot in our clinic. We have a lot of trial sets available. And in this case, what we do is we will select a trial lens based off of the parameters that we've measured on the patient, find the best one after we've evaluated fit, and then when we perform an over-refraction and use this information to order a lens. I like this again because I like to be able to see how that lens is interacting with the lid, how it moves with the blink, which is not something you can do necessarily with an empirical fitting. So when you're choosing your first diagnostic lens to put on, what are some of the considerations that you need to have? One is overall diameter. So I will often look at the patient and try and choose a strategy that I think will be successful with them. So do I want a lid attached fit, or LA, or an interpalpebral fit, IP? So an LA fit is where the GP is still underneath the upper lid after the blink, versus an IP fit, the GP is below the upper lid after the blink. So it is within the palpebral aperture. Based on the corneal diameter, palpebral aperture size, and lid position, then we can make a selection. On the table below are some general guidelines of what you can use to select if you're going to opt for a smaller diameter GP or a larger one. So I think these are pretty intuitive. If the patient has a small palpebral aperture size and a small cornea, or if their cornea is also steeper, you may opt for a smaller diameter. And the reverse is true for a larger. If you have a larger palpebral aperture size, larger cornea, and flatter cornea, you may go for the larger diameter. Now, there are some exceptions, I find, to this overall diameter general rule. One of them has to do with the lid position relative to the upper limbus. This may affect the fitting strategy. So in general, it's easier to achieve a lid attach fit when the upper lid is overlying the limbus. And lid attach fits tend to be more comfortable initially. So a lot of practitioners will try to achieve that fit if it's possible. If you look at the images below, again, of our 3 different eyes, you can see that the image on the left has a smaller palpebral aperture size and the lid overlies the limbus. And this may be able to achieve a lid attach fit much more readily than the image on the right, where you see a very large palpebral aperture size and the upper lid actually is above the limbus. You can imagine that if we try to fit a lid attached fit on that eye, the lens may be fairly decentered. It would not necessarily have the optics nicely over the pupil. And you may think, well, why don't I just keep making the lens larger so that it's both lid attached and over the pupil? Well, the last point on here explains that you can't have a diameter that is so big that you don't have proper movement or tear exchange. So in this case, with that large palpebral aperture size on the right-hand side, I opt for a smaller diameter GP, which would give me an interpalpebral fit. Because if I go too large and the lid starts picking the lens up, you may not have a stable centration of the optics. So you have to kind of balance those two things. Look at not only corneal diameter, but also look at lid position and decide what will be the best strategy. So what about base curve selection? I've listed here a table that is the Berkeley method for base curve selection. And you may be thinking, do I really have to memorize like a lot of calculations to figure out what base curve I need to choose? So I have 2 methods here. The Berkeley method shows you, based off of the delta K or the toricity of the cornea you measure from keratometry, what you would choose for your initial base curve lens. But I think it's helpful to understand why this calculation is the way that it is. If you have a patient with low corneal toricity or no corneal toricity, such as 0 to 1/4, then you have a relatively spherical cornea. So if you were to put a spherical GP on that and it was too perfect of a match, you may limit tear exchange, which is why the first lens chosen here shows a base curve initially that is half a diopter flatter than your flat K. That allows for a little bit of wiggle room in tear exchange while still giving a very good fit in the center. In the second row, that is a half to 3/4, now you already have a little bit of built-in toricity into this cornea, so you can fit on flat K knowing that you will have already a little bit of built-in wiggle room there. As we get steeper, we have to balance between the 2 meridians being fairly different from each other. As we get more toric. So if your toricity is between 1 and 2 diopters, then you need to find a balance between those 2 meridians to achieve a better fit. So in this case, our calculation is you take flat K and then you add delta K over 4, effectively going a little bit steeper. That way we're not having too much edge lift on that steep meridian, which could potentially cause the patient some discomfort. Once you get to above 2 diopters, you may find that you have a difficult time fitting that lens with a spherical modality, and you may need to consider a bitoric GP. An alternative method, if you don't want to remember this whole table, is you can take average K and subtract 3/4 a diopter. Oftentimes this works pretty well and is fairly similar to the other method in terms of the resultant base curve. So choose whatever method you like. Remember, this is just a starting lens. You're going to see how it fits, and if it's not fitting the way that you want it, you may have to modify from there. Okay, secondary and peripheral curve guidelines. Typically, the flatter your base curve, the flatter the secondary and peripheral curves will be, because this is going to allow that back surface of the lens to follow the general topography of the cornea. Most normal corneas are going to be aspheric, where they're steeper in the center and flatten as we move to the periphery. And so the lens surface should also reflect that shape so that we have better alignment. Generally, the secondary curve is about 1 millimeter flatter than the base curve, and the peripheral curve is often 3 millimeters flatter than the base curve. But I will say that you're typically not selecting these options when you are putting a diagnostic lens on, because a lot of labs will have proprietary lens designs where these peripheral curves are already standard for a given base curve. And they designed this based off of the average eye will do well with these types of curvatures because cornea shape will be relatively similar in the periphery for a normal eye. Now, if that's not the case, if the patient is a slight outlier, then obviously you may have to customize these curves yourself and make some changes from the standard design. So once you choose your base curve, your secondary and peripheral curves will often fall in line with that, and you may have to adjust them afterwards. Sometimes, if you have multiple peripheral curves, you may also have blends between these curves. These are essentially blending between the junctions to help with patient comfort on the backside of the lens. So we may describe these blends as light, medium, or heavy. So now you've collected your information. You've decided that you know what diameter you want to choose, you know what base curve you want to choose, and so you're ready to put your trial lens on, right? I'd like to take a moment to pause and talk a little bit about whether or not to use anesthetic in a diagnostic GP fitting or not. I asked myself this question when I was a student because I thought to myself, should we be using this to help with patient comfort? Or if we use it, are we going to give the patient a false sense of what that lens actually looks like? So I did a little bit of research to look to see if any studies had been done. A study by Bennett et al. In 1998, so this is a fairly older study, looked at 80 subjects who had no previous GP wear. And they divided these subjects into the either anesthetic group or the placebo group. And the anesthetic group received the drops at both the fitting and the dispense visits. So at the conclusion of the study, 70 subjects completed it. So that means there were 10 that dropped out. And 80% of those dropouts were in the placebo group. And what they found as a conclusion from their study is that the anesthetic group had fewer dropouts, and they also had improved initial comfort, which is no surprise to me. It seems obvious that they would have improved initial comfort because of the drop. However, what was interesting to me is they found that upon questioning their patients, they had better adaptation process and better overall satisfaction at 1 month when they had the anesthetic as opposed to the group that did not. So this suggests to me that there is some more long-term effect of using the anesthetic at that initial fitting and dispense visits than just that initial comfort. So I looked at another study. This was done a little bit more recently in 2017. It had a fairly similar design where they divided their subjects into either the anesthetic group or the placebo group. In this particular study, the topical anesthetic group only received drops at the fitting visit, but not at the second visit. They did find small increases in hyperemia and corneal staining during the fitting, but this wasn't necessarily associated with the anesthetic group. It was seen in both groups. So it wasn't statistically linked to either one. What they did find, again, is that the anesthetic group had improved initial GP comfort, but they also reported reduced anxiety during adaptation and prior to subsequent GP wear later down the road. So again, some sort of lasting impact has occurred here using anesthetic. So are you going to give your patient a false sense of security when you use anesthetic, or are you going to help them in the long run? I would say that there's still some back and forth amongst my GP colleagues as to whether or not to use anesthetic. I would say the choice is yours. One of my colleagues has a procedure where I think it's a nice way to introduce it. She'll put the GP on first without anesthetic and tell the patient, this is the worst it's ever going to feel. You know, this is the beginning of the adaptation process. And then she will put the drop in and say, this is sort of a fast, accelerated adaptation process where the hope is after you've worn the lenses for a while, you're no longer going to feel them on your eye. So this is what you can look forward to if you can get through that initial adaptation. And I thought that was a nice way of presenting it. Another reason why you might end up using anesthetic is that the patient is blinking and tearing a lot to the point where you're unable to assess the fluorescein pattern or perform an overrefraction. Then it may be beneficial to put that drop in just so you can collect the appropriate data and get your lens ordered. So let's talk about evaluation of the fit once you've put that diagnostic lens on. We break our fit down into 3 general areas. We look at the lens position, which includes, is the lens lid attached or interpalpebral, and how is it centered over the pupil? Then we look at the movement when the patient is blinking. It can be described as none, meaning that GP is really bound, which is obviously not a good thing. It could be minimal, adequate, or excessive. If the movement is vertical, that's typically what we're looking for, but you also may want to pay attention to if the movement is more C-shaped in its pattern, which may suggest that the lens is maybe on the flatter side. We'll talk a little bit more about this in a moment. You also want to look at the lens-cornea relationship, or the fluorescein pattern. I personally like to work from the center outward because I find that if your center fit is not appropriate, then generally the rest of the fit is not going to be appropriate either. And once you can get that central part of the lens fitting better, typically the rest will follow. So looking at the central or apical fit, you can describe it as apical alignment, which is where the back curve of your GP and the front curve of your cornea are very similar in shape. And you'll see a very thin, even green sheen of fluorescein.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
Apical clearance means that you have some space between that GP and the cornea, allowing for pooling of that fluorescein. And apical touch is absence of that fluorescein, where the lens is actually landing on the cornea. And that may look darker in color because there's an absence of that dye there. For apical clearance and apical touch, you may also want to relatively quantify them as minimal, moderate, or excessive. For the mid-peripheral bearing, this is where the lens has to land on the eye. We need it to stabilize somewhere. It can't just be floating up over the eye. It needs to actually touch down. And the preferred place for it to touch down is not right in the center over the pupil where we see through, but in the mid-peripheral portion of the cornea. This bearing pattern may be spherical. As you can see in this top photo, that mid-peripheral bearing pattern is more spherical. Or it may be toric, which you might describe as with the rule, against the rule, or oblique. I'll show you a couple examples of toric corneas a little bit later. You may also want to describe the bearing as soft, moderate, or excessive. Usually soft bearing is going to have feathery borders, not be so dark and not be so wide, versus excessive bearing, you will see a very harsh distinction between the pooling pattern and the bearing pattern. The last thing I describe with the fluorescein pattern is the peripheral clearance. How is the edge looking? You can describe the edge lift as none, minimal, excessive, or even adequate. So what is an ideal fit? There's a range of ideal. There's not one perfect, fit, but there are some things that we will look for. For lens position, if it's possible, we may try to get that lens to lid attach because, again, generally it is more comfortable. But again, you can have a very good fit that is interpalpebral, so it does not have to be lid attached. But you do want that lens position to be well centered over the pupil for good optics. In terms of movement, the movement should be slow, central 1 to 2 millimeters of movement in a vertical orientation. You do not want a lens to rapidly move where it drops to the inferior lid between blinks because that can cause the patient discomfort. Or if it is moving so much that the pupil is moving outside of the optic zone, that could become visually significant for the patient. For the fluorescein pattern, we generally will accept a range. Minimal apical clearance, alignment, or minimal apical touch might all be acceptable. Mid-peripheral bearing should be soft and distribute weight evenly. You want to avoid it being too excessive, where it may be causing staining underneath that area of the lens when you remove it. And the peripheral clearance should show adequate edge lift that will allow for appropriate tear exchange. So it shouldn't be so thin that you're not getting tear exchange and the lens is potentially unhealthy. Or you don't want it to be so lifted that the patient feels the edge and feels it's uncomfortable. So let's go through a couple of photos that describe evaluations of fit. Now this is a static photo, so we're not going to be describing movement, but it just gives you a better idea of how you would go about describing a fit. And then we'll go into some videos that show some movement. So in this lens, we have a lid attached. You can see it's underneath the upper lid, well centered. You can faintly see the pupil is pretty well centered in the center of that lens. The fluorescein pattern is notable here. You can see the brighter green fluorescein in front of the pupil, but it doesn't look so excessive that the pupil is obscured because the fluorescein fluid is so thick. It's not having any bubbles, so I would call this minimal apical clearance. If we move out to the mid-peripheral area, you can see that the bearing is pretty soft, the borders are feathery, and it's not too wide, and it's in a spherical shape. So soft mid-peripheral bearing here. And then the edge lift is adequate as well. So this is an example of a well-fit minimal AC lens. So let's move on to this lens. This lens has lateral decentration. You can see the pupil is not that well centered within the optic zone of the lens. It also has moderate apical touch. It may be a little hard to see, but hopefully you can appreciate that the area over the pupil is showing bearing. There's a dark area there relative to kind of a crescent-shaped area of pooling adjacent to it. The reason that you see a little bit of pooling there is because this lens is decentered off to the side. So don't be fooled into thinking because you see fluorescein there that lens is actually clearing the apex. It is actually touching it. And if you were to nudge this lens to the center, you would probably see this area of touch much more prominently. You can see that there's moderate edge lift in the direction where the lens is pushed towards the center of the cornea. And again, this is a product of the lens being decentered. You can see on the opposite side, there's less edge lift. And this is a excessively apical touch fit, flat fit. So let's look at this one. This is an intrapalpebral, so you can see the upper lid is not covering the superior portion of the lens here, and it has slight inferior decentration. Unlike our first picture, hopefully you can appreciate that while there is apical clearance, this is much more apical clearance than the first image. There is a lot brighter area of fluorescein, and you can even see bubbles here, which suggests excessive clearance. Additionally, although the mid-peripheral bearing is spherical, you can see that here it's much wider, it's darker and more distinct in its borders, and this is what I would describe as excessive mid-peripheral bearing. And additionally, the edge lift is quite thin and insufficient. So all of these are fairly common characteristics of an excessively steep fit. So looking at all of three of these in comparison, hopefully you can start to see some of the patterns that you'll see when a lens is too flat or too steep versus when it's more ideal. So we have found that an acceptable fit has a range. It should satisfy the criteria listed here. Your patient should have clear and stable vision, good comfort and overall wear time, an appropriate fit, and good corneal health. When you remove that lens, the cornea should look healthy. And so I have found that even though I told you a quote-unquote ideal fit may be minimal apical clearance through minimal apical touch, I've had patients who I would describe as having moderate apical clearance where these criteria are satisfied, and I'm okay with finalizing that lens. So, remember, there is a range. Just make sure that these criteria are satisfied so that your patient has a healthy fit. So when you're instilling fluorescein to evaluate the lens-cornea relationship, I think it's best to instill it with not too much dye. So if you put a large globule of fluid and dye on there, too much fluorescein can affect your observations. Also, I tend to instill it at the superior portion of the bulbar conjunctiva, usually because when you're initially fitting the lens, the patient will be more comfortable in down gaze and with the lids not interacting with the edge as much, because often that is what they're feeling in terms of their initial lens awareness. So that can be helpful in terms of comfort. I also think it's really useful to use a Ratten filter that will help with your fit interpretation as it accentuates the fluorescein pattern more. So I always ask my students when I show them these pictures, how would you describe these two fluorescein patterns? And inevitably, they will tell me that the left photo looks like it has excessive apical clearance and the right photo looks like it has apical touch. And then I will tell them that this is actually the same lens on the same eye at different points in the fitting process. So the left image is right after we've put the fluorescein dye in, and a lot of it is actually coating the surface of the GP. So they're misinterpreting fluorescein in the tear reservoir, or the tear film, which is in front of the lens, instead of the fluorescein pattern that is behind the lens. if we waited a moment, then it actually looked like the image on the right, where you can actually see this is a bit of a flat fit. So I always recommend waiting a moment after you put fluorescein in and letting some of that superficial dye dissipate before you make your assessment. So let's go over some videos that will show you some of the dynamic movement of a lens on the eye. So looking at this lens, I would describe it as an interpalpebral fit. The lens is not underneath the upper lid after the blink. I would say it's relatively well centered over the pupil. However, I would say that this has excessive apical clearance. You can see that there are some bubbles underneath the lens, and the fluorescein is quite bright. Additionally, the mid-peripheral bearing is spherical, but a little bit more moderate. It's pretty wide and dark with more distinct borders. And the peripheral system is fairly thin. It does have adequate movement as the patient is blinking. You can see it has vertical movement between 1 to 2 millimeters, so that amount of movement is good. So in this case, this is not a egregiously poor fit lens, but I think that we would do best to choose a lens with a flatter base curve in this case. So in this video, you can see that the lens is quite decentered. It is picked up by that upper lid, but then it rapidly falls down to the lower lid. You can see that when it is centered, there's an area of darkening over the pupil. This is suggestive of a flat fit where there's apical touch. The C-shaped movement is also suggestive of apical touch. The reason that a lens will move in a C-shaped pattern is that the flat base curve of the lens is trying to migrate to the flatter part of the cornea, which is our peripheral cornea. And instead of landing on top of the apex, it's avoiding it. So it's making the C-shaped rocking motion. So this is an example of a flat fit. And so this is a way that movement can help us determine whether or not our lens is appropriately fit. In cases where the lens is not centering naturally, you can also use the lower lid to gently nudge the lens into center, and then you will be able to see the relationship between the apex and that base curve. And in this case, it would have been quite flat. This lens is interesting. When I look at it, the lens just barely is underneath the upper lid, so it is barely interpalpebral in this case. It is also fairly well centered. This lens is somewhere along the lines of apical alignment to minimal apical touch. It's very, very thin right over the apex, which is why it looks slightly darker there. When we look at the mid-peripheral bearing pattern, it's fairly soft. It doesn't have really harsh borders. It's pretty thin, and the peripheral system is more adequate here. This lens also has pretty good movement on blink, vertically with not excessive dropping to the lower lid. So this is actually a pretty well-fit lens, in my opinion. And one last one here. As a note, this is a spherical GP on a toric cornea. So hopefully you guys can appreciate what that looks like if we were to put a spherical GP on a toric cornea. So here, this patient has a width the rule cornea, and you can see that there is a lot of central pooling, enough that there is sometimes a bubble that forms in that pooling area. So this is an excessive apical clearance fit. But when we move to the mid-peripheral area, hopefully you can see that there is bearing in the horizontal meridian, but there's not bearing in the vertical. In fact, there is pooling in the vertical meridian, and this is reflective of the fact that this patient's cornea is steeper in that vertical meridian. There is more space between the lens and the eye here, allowing for this column of pooling to occur. So this is a width the rule cornea with a spherical GP on. So what would it look like then if I put a bitoric GP on this patient? So this is that same eye, and this photo shows that there is more of a spherical appearance to the fluorescein pattern when you put a bitoric lens on a toric cornea. And this is because the Base curves will better match the curvature of the patient's cornea, allowing for this more even pattern. This is still a little bit of a steep lens. We only had a steeper one in office. But ideally, you should be able to get a lens that behaves more like a spherical GP if you fit it appropriately. So, once you've found your best fitting diagnostic lens on your patient, then you're ready to perform your over-refraction or your OR. For the majority of patients, just a spherical OR should yield pretty good visual acuity because you are going to be using that tear lens to correct their corneal astigmatism. However, in some cases, if you're not getting the expected acuity, you may want to perform a SCOR or a spherical cylindrical over-refraction and see if there's any residual astigmatism there that may be from other causes such as the lens. Don't forget, you may need to vertex your over-refraction if it's over 4 diopters. So when you're placing your GP order, here are some of the specifications that you need to put in to make sure that you have a complete order. So you may need a design if applicable. What I mean by that is some designs are proprietary that already have their peripheral curves set in place for a given base curve. Now, if you deviate from the standard design, now you have a custom GP, in which case you need to specify all of your peripheral curves. You want to specify a material. So what is the plastic your lens is going to be made out of? You need your diameter and your OZ, your optic zone. You will need your power that is a resultant from your over-refraction with the power in the lens itself. You need your base curve. Peripheral curves, again, listed only if you are not using a standard proprietary design. You can specify if you need a blend, center thickness, and color. A lot of times the convention is we will use green color tint for the right lens and a slight blue color tint for the left. And this will allow the patient to tell the difference between their two in case they're worried they may have mixed their lenses up. So when you're selecting your lens material, remember that each material has an inherent decay value and wetting angle associated with them. So higher decay is associated with higher oxygen transmissibility. But remember, this is also dependent on thickness. So the further that oxygen has to travel through, the higher the oxygen transmissibility material we may want to choose. Lower wetting angles are associated with lower wettability. So in the cartoon below, you can see that if we have a very large wetting angle, the fluid is sort of beating up on the surface. And this may be seen in patients who have dry eye, a lot of ocular surface disease. And so you may try to choose a GP material that has a lower wetting angle to help with this problem. So let's show this video here. This is an example of someone with a lot of dry eye and poor wetting with the GP on. And hopefully you can see where that fluorescein on the surface of the lens is very quickly evaporating after the patient blinks. So this lens is not wetting very well. The patient also has some tear film debris, and down at the bottom of the lens you can see those little evaporation points. So they may benefit from a lower wetting angle material. But at the same time, I want to remind you all that if your patient has ocular surface disease, you should be managing that in conjunction with your contact lens fitting. Because if you don't, then even if you have the best wetting angle material, your patient may still have issues. So remember, always take care of the underlying dry eye too. So when you're ready to dispense your lens, you want to look at the initial fit assessment of the lens that you ordered. You check your visual acuity and your over-refraction. Ask the patient about their comfort. And then you can perform application and removal training with the patient because we need to make sure that they can satisfactorily do this before sending them home with it. You can also send them home with some sample solutions, review the care and handling, discuss with them normal and abnormal symptoms. What is a normal adaptation symptom versus an abnormal symptom that may be suggestive of a problem? Talk to them about wearing schedule, and then schedule a follow-up appointment. So some general considerations about wearing schedule. A lot of patients are not going to be very comfortable at the onset, and you have to educate them that this is normal. A lot of times you will find that until they can achieve 8 to 10 hours or longer of wear time, they may not really be fully comfortable and fully adapted. So you may be really tempted to try and make changes of the fit if you're finding your patients complaining that they're not really fully comfortable yet. But you may want to wait a little bit and make sure that they've had ample time to actually adapt before you start jumping into different changes. So for my patients, I like to start them out with around 2 to 4 hours of wear time the first day, and they can add 1 to 2 hours per day for up to 10 to 12 hours a day for the first week. So basically just gradually, incrementally increasing how many hours they're wearing that lens each day, and hopefully they can reach the 10 to 12 hours mark by the time they come in for their follow-up. You can extend this further up to 12 to maybe even 16 hours a day the second week if they've adapted, because a lot of our patients who wear these lenses really don't like the vision they have in their glasses or their soft lenses, and so they prefer to wear it for all their waking working hours. When they come in, you want to educate them to please wear their lenses at least a few hours prior to the follow-up visit so that lens is nice and settled when you evaluate it. So, what are the elements of follow-up care? When they come in after they have been adapting to their lenses for 1 to 2 weeks, ask them what their average wear time is, like how long have they been able to wear it each day on average, what their wear time that day is, how long have they had it in, what is their comfort on a scale of 1 to 10, 1 being, oh my gosh, get this lens off my eye, and 10, I don't feel it at all. Ask them how their adaptation process has been going, how their vision quality and the stability of their vision has been, and ask them if they have any care or handling issues. Once you've gotten through the history, you can perform some of the similar aspects of our dispensing visit. You'll perform your visual acuity and overrefraction. You'll check the lens fit evaluation with fluorescein behind the slit lamp. Then you'll remove the GP and perform a slit lamp evaluation without the lens on to make sure that the ocular surface health is good. After that, you'll make a assessment and plan. So you'll decide, do I need to reorder a GP, make any changes, and then schedule additional follow-ups as needed after that. So let's review briefly some basic troubleshooting before we wrap up here. If you have a central fluorescein pattern that exhibits too much pooling or too much apical clearance, one of the easiest fixes is to flatten the base curve. This will decrease the space between the lens and the cornea. You may also decrease the diameter if the diameter itself is too large. A lot of times larger diameter lenses are going to have a higher sagittal depth, and this will give the appearance of more pooling. So either one of these options is a possibility, although I'd say for the majority of people, flattening the base curve is usually that first best step. If you have too much touch or too much bearing, you can do the opposite. You can steepen that base curve, or you can also increase the diameter to get more space or more pooling effect underneath the lens. Again, typically base curve would be my first choice of modification if I feel that my diameter is appropriate. Keep in mind that if you're changing your diameter by about 0.4 millimeters, this is effectively giving you about what would be equivalent of a quarter diopter base curve change in terms of pooling. So if I make my diameter bigger by 0.4, it'll potentially look like I have a deeper lens. So to compensate for this, let's say that you were happy with the way that your fluorescein pattern looked, but you want to change the diameter. You may adjust the base curve accordingly, adjust the base curve accordingly to compensate for that sagittal depth change that you're gaining from changing the diameter. So I would say a quarter is not a huge deal, but if you're making a bigger diameter change, like say 0.8, which is more like a half a diopter effective change, then that might be worth making the adjustment on the base curve. For the peripheral system, if you have insufficient edge lift, so that's inhibiting tear exchange, that suggests your peripheral curves might be too steep or too narrow, so you may want to flatten or widen the peripheral curve there. Excessive edge lift, the PCs are typically too flat or too wide. Your patient may complain of lid interaction and awareness. So in this case, you may want to steepen or narrow your peripheral curve. Decentration is oftentimes a issue with the alignment not being appropriate. So when you see inferior decentration, this may suggest that your lens is too steep or that you're not getting enough interaction with the upper lid. So you might consider flattening the base curve, increasing the diameter to increase that interaction with the upper lid, You may lenticulate the lens, which can help reduce the overall weight of the lens, which might be causing it to drop downward, or decrease the center thickness if that's appropriate. Superior or lateral decentration is common with lenses that are too flat or if there's excessive interaction with the upper lid. So we're doing a lot of the opposite things. Here we can steepen the base curve or decrease the diameter. We may also consider a thinner edge or increasing the center thickness if that's appropriate. So here are a couple of resources that you guys can access via the internet. The Gas Permeable Lens Institute is a really great resource, not only for corneal GPs, but a whole host of other specialty lenses. I find this tool, the GP Click and Fit, a fun way for you to engage with a case and try out different lenses from this fitting set to see how it looks on this patient. So this is something that you guys can access anywhere in the world. They also have some literature available to dispense to patients about how to care for GPs. This includes wear and care, handling, wearing schedule, how to apply and remove the GP. So I think this is nice because when the patients get a lot of information in office, it can be a lot for them to remember. So having a written form like this can be helpful for them when they're practicing at home after you dispense the lenses. The AOCLE also has a similar dispensing handout that can be requested from aocle.org. So here are some of the websites where the references I just discussed are available. And thank you for your attention.